Yes, you already have atherosclerosis, and I'm going to tell you why. First of all, let's talk about the meaning of the word. So athero, the first part of the word, just refers to the buildup of fat or lipid, and sclerosis just means stiffening or hardening. This is a process that occurs early and slowly in one's life. In fact, there was a study that showed from autopsies of young people who died from causes not related to atherosclerosis that many people between the ages of 15 to 34 already had fatty streaks in the aorta, and as you'll see shortly, fatty streaks are the earliest stage of atherosclerosis. So from this data, we know that by the late teens, the process of atherosclerosis is already universal in modern populations, and this was called a P-Day study. Let's talk a bit about the histology of atherosclerosis. It's a stepwise process that happens over many years, and the first initial lesions, as we just read about, are fatty streaks. As these progress, we get immune cell involvement, such as macrophages, and as these get involved, they start to enter the arterial wall and create more inflammation with the accumulation of intracellular lipids and the formation of foam cells. In one of my previous videos, I talked about the calcium score. If you want to see, if we're talking about calcified plaque, this is actually quite a late stage of atherosclerosis. Here are some images under the microscope of a vessel with severe atherosclerosis. But on the furthest right, we've got a macrophage, which is one of the cells with a key role in the process of atherosclerosis. A bit about the calcium score. A negative calcium score does not rule out atherosclerosis. Interestingly, statins and exercise can increase the calcium score, but this can be quite advantageous. And if you want to find out more about that, go and have a look at my previous video. It's important to know that anywhere in the body where you have arteries, you can have atherosclerosis. And you can have body-wide manifestations of atherosclerosis. The two most severe and late-stage ones being a gradual chronic severe narrowing of the lumen, but also a somewhat unpredictable sudden plaque rupture. Let's move on to some risk factors. These are the non-modifiable ones for now. This will be your sex at birth, or your chromosomes, your age, and also genetics. For example, certain people are born with a PCSK knockout gene, which causes them to have very low LDL for the majority of their lives. And these people rarely ever get heart disease or atherosclerosis in their body. Conversely, there are conditions where the level of LDL or atherogenic particles is abnormally high, and these patients develop very early atherosclerosis. These are the modifiable risk factors and include smoking, high blood pressure, a poor lipid panel including high LDL, ApoB or LPA, poor diabetic control, high saturated fat diet, sleep apnea, and of course stress. Let's talk quickly about LDL, ApoB, and lipoprotein A. Here we have an LDL molecule, and ApoB is just a lipoprotein which gives a bit more structure to the molecule. Because each LDL particle has exactly one ApoB molecule, ApoB can be used as a proxy for the number of LDL molecules. LDL-C, which is what you normally get in default labs, is just the total cholesterol mass, and cholesterol is on the inside of the molecule. Certain LDL particles may have more or less cholesterol, so the cholesterol mass by itself is not an accurate marker of the number of LDL particles, and the number of LDL particles is what matters when it comes to atherosclerosis. Lipoprotein A is a form of LDL with an extra structure, this extra C-like structure on the side, which gives it more atherogenicity. In fact, an LPA particle is about 3 to 5 times more atherogenic, and about a quarter of the population has this. It can contribute to severe atherosclerosis and the development of calcific aortic valve disease in younger patients, despite an otherwise normal cholesterol panel. And obviously these patients need a much lower LDL target. There's a lot of debate online about whether LDL is even significant for atherosclerosis. However, there's a lot of evidence that LDL has a causal relationship to atherosclerosis, and the evidence supporting this is genetic evidence in the form of Mendelian randomization trials, clinical trials, and epidemiology. And in a future video, I'll talk about Mendelian randomization trials. Here is a graph demonstrating many trials and evidence showing the relationship between LDL and cardiovascular disease. We have many existing and emergent therapies to deal with the problem of LDL. Of course, we all know about statins, which are first line and very effective. Some newer medications include the PCSK9 inhibitors, which is an injection every month or so. And now we are coming out with oral PCSK9 inhibitors. These are very effective at reducing LDL cholesterol. Even new medications include Inscleran, which is a form of gene editing which can dramatically reduce LDL. In fact, we've seen evidence of plaque reversal in some trials. Prevention is key in cardiovascular disease. Prevention means that you'll have fewer interventional procedures, fewer deaths, and fewer long-term complications, which means fewer medications needed. The takeaway message from this talk needs to be that atherosclerosis starts very early in life. You need to get your LDL, and if you have a family history or other high risk factors, you should get your ApoB and your LPA checked. Do not be complacent. Just because you're conventionally fit or you lift weights does not mean you are immune from atherosclerosis. However, I hope that atherosclerosis will soon be a disease of the past. In fact, we should think about it as an area under the curve philosophy. Just like in rheumatoid arthritis, we don't see deformed hands anymore, or this is very rare due to the newer medications and disease-modifying drugs. And in the same way that we don't see AIDS with strict compliance to medications for HIV, we shouldn't see severe atherosclerosis with the knowledge and medications we have today. The key equation is that risk factors times time equals atherosclerosis. We can't change time, but we can lower risk factors from day one. And this is just the same slide. We have to talk about reducing risk factors as early on as possible.